Good afternoon. This is Dr. Jeff Gelblum, your friendly neurologist from down here in Aventura, Florida. And purpose of today's discussion is to share with you what is the emerging information regarding the COVID antigen or the COVID viral test, which is a blood test, and the COVID antibody test. I've gotten lots and lots of requests, lots and lots of inquiries from my patients as well as all of you out in Facebook land regarding what does it mean to be COVID positive. When we read about these daily COVID numbers, almost 800,000 nationwide in the United States, I believe it's up to 26,000 and change here in South Florida. What does that mean? Where does that number come from? Well, that number comes from the antigen positive viral tests, meaning there has to be antigen that is found, COVID antigen protein particles that are found either in the nasal swab or the back of the throat. Those are verified tests that are now done in testing centers. Those antigen tests are conducted in accordance with CDC guidelines. So in order to be recorded as a positive COVID patient for either a national statistical basis or for local Florida reporting basis, you have to have antigen positive. You have to be an antigen positive patient. And that antigen test, that ability of that nasal test to determine whether you have actual viral shedding that is coming out of your upper respiratory system, that actual test is based upon this technology called PCR, polymerase chain reaction. So at this point, before we go any further, I'm going to recommend that you do what I always do. Go get an envelope, go get a pen, and you're going to write some items on the back of an envelope. I'll wait. That's enough waiting. You should have an envelope and a pen always when you talk to me. And I always say there's no thought in this world that cannot adequately be expressed on the back of an envelope with a pen that you basically steal or pick up off the ground, but don't pick it up now because obviously it could have viral attached to it. But you should have a pen and an envelope at all times in case if you need to jot down any notes or understand a concept. So PCR is the scientific name for polymerase chain reaction. That is considered to be the valid diagnostic modality for determining if you are COVID shedding, COVID infectious. And that is how COVID is now reported to the CDC, which keeps these daily data for the United States of America. And of course, that is then transmitted to the World Health Organization so that we can have a global number of COVID infections. Of course, now that the United States is no longer funding the World Health Organization, I don't know whether our data is going to be included or not, except for the fact that we are now the largest cohort of COVID carriers in the entire world. But be that as it may, antigen positive means that you've got some component of the COVID virus that is actually shedding into your nasal cavity or the back of your throat. So when they jam that swab in the back of your nose or in the back of your throat, they're then taking the material on that swab and they're sending it all out to a recognized lab that will utilize what we call PCR, polymerase chain reaction, to determine if there are viral particles on that swab. If there are viral particles on that swab, then by definition, you are shedding virus. That being said, it's important to understand that the recognized technology for determining COVID incidence, COVID prevalence within a population is predicated upon this PCR, polymerase chain reaction technology, and the valid laboratories that are out there will use PCR. So when you go to the hospital, when you go to one of these testing centers that are popping up all over the place, they will be utilizing PCR technology to determine if you are antigen positive, meaning if you are in the throes of a COVID infection, meaning if you are actually infectious. So PCR is what you want to know, is the three initials you need to bear in mind for the valid test to see if you are actually shedding antigen, meaning if you are infectious. So PCR means antigen. Now let's talk about antibody. What does it mean to have a positive COVID antibody? Well, we all know what antibodies are. Antibodies are the proteins that are made by your body in response to an infection. And you can have antibodies to bacterial infections. You can have antibodies to viral infections. So the way we can determine if you have ever seen COVID is with an antibody test. If you're not actually infectious, or if you've never been symptomatic, or if someone in your house has had COVID, but you don't know whether you've ever had it because you've never been symptomatic, then at that point, because you're not actually symptomatic or maybe infectious, it would be very wise to get an antibody test, a COVID antibody test. And what does a COVID antibody test look at? Well, that's a different set of initials. Remember, when we talked about antigen positive, we relied upon a technology called PCR, polymerase chain reaction. But when we talk about valid antibody tests, we use different initials in that case. And we use something called ELISA, E-L-I-S-A. Not like Eliza Doolittle, but ELISA is an acronym for the evaluation of immunofixation in response to the antibody. And this is a blood test. So the antigen test is a swab from the nose or the back of the throat, but an ELISA test is specific for the antibody, and for that there has to be a prick of blood because the blood contains the antibodies. And this is a very important concept because these testing facilities, if you want to call them facilities, are basically popping up all over. In the back of a parking lot of a mall, in front of a Walmart, by the Piggly Wiggly, near the hardware store, maybe in your parking lot at home, maybe your doctor is offering them. The point is, there are not many valid antibody tests that are available to us at this point of time. So here we are, end of April. We would like to know who has seen the COVID virus, and in order to answer that question, we would have to have an antibody test that would be readily available. Unfortunately, the antibody test is not readily available. There are lots of antibody tests on the market. However, at this point in time, not many of them are reliable, not many of them are valid. In fact, if we want to look at the two best antibody tests that are out there, they have to utilize ELISA technique, E-L-I-S-A, meaning they have to rely upon pricking some blood to then look at the actual antibody levels in the bloodstream. And there are multiple antibodies that test would look for. But the two valid tests right now, there's only two that really have the degree of specificity and sensitivity that would be required to help open things up or give you important useful information, and that would be made by Roche or Abbott Labs. Those two companies right now are really at the forefront of developing valid antibody tests for COVID virus. Again, there are lots of tests on the market, and unfortunately, the Food and Drug Administration has said, okay, if you have a test, put it out there. We're not necessarily going to hold you to validity and reliability. But the point is, if it's not valid and reliable, why even bother? So at this point, I'm recommending that if my patients are requesting an antibody test to determine if they have, in fact, been exposed to COVID-19, the two valid ones are Roche and Abbott. And let me give you a little bit background about the statistics. This is why you need to have your envelope, and this is why you need to have your pen. Right now, the antibody tests, the vast majority of antibody tests that are out there are probably no more than 95% valid, reliable. So you say, well, that's pretty good, 95%. I would take that to the casino all day long. But the problem is 95% means, well, yes, 95% of the time it is going to be correct, but 5% of the time it's going to be wrong. And I want to remind you that right now, the incidence of COVID-19 in the overall United States population of 330 million, the overall incidence of the disease as of today is still under 800,000. Now, that's a good thing, but that represents less than 5% of our total population. So therefore, if the incidence of the disease is less than the false positive rate of your test, you have a very bad test. So that's why in my office, with my patients, it's imperative that we have a test that approaches 100% validity, 100% reliability. And that's where the Roche and Abbott lab tests really hit the mark. Because unless you're approaching 100%, the other tests that are out there are not going to be reliable for you to make a decision as to whether you have actually been exposed and as to whether you can actually go back to work. Because remember, the good news is, because of all the social distancing that we're doing, the good news is that we've managed to really dampen down the overall prevalence of this deadly disease in our national population. So we've probably kept this disease at around maybe 0.5% to up to 0.7%, and that's good. But that low incidence is far lower than the false positive rate of these tests that are out there. So therefore, when you get that type of situation, it's very important that you shop around for your tests, because testing quality is very important to determine the validity of your answer. So just like you would shop for a good pair of shoes, just like you would shop a restaurant, just like you would shop for anything else, you have to be a savvy consumer and you have to know exactly who makes the test and the validity of the test. And unless they can tell you that it's approaching 99 to 100%, you're probably not getting a good test. And in fact, there's some bad actors out there. If you've heard of Alltest, Biotech, Wandfo Biotech, these are actually made in China. These are probably no good because the false positive rate is approaching 5%, which actually exceeds the national disease prevalence rate. And when that happens, your testing data is going to be very inadequate and not useful for you to make a good clinical decision about whether you should go back to work or whether it's safe to go out without a mask or all of these other things. So first component of today's discussion is to talk about the types of testing that should be done. If you're looking to see if you're actually infectious, you want a PCR antigen test, and if you're looking to see if you've ever seen the virus and whether you have any immune response to the virus, then that would be called an ELISA antibody test. And for purposes of this discussion today, at this point in time, the only two reliable ELISA tests that I'm aware of are the Abbott Labs test and the Roche tests. Are these tests readily available? Nope, sorry they're not, but they will be hopefully within the next few weeks. And at that point, we're going to be able to do broad spectrum national testing to determine if it is safe to go back to work. So that's the first component of today's discussion, to give you insight as to what constitutes the corona antigen, which is actually infectious, or the corona antibody, which means that you have seen the virus before and that you are now quote-unquote immune. But what does that mean? Am I immune? And if I'm immune, for how long? I don't know about you, but I get a tetanus shot every 6 or 7 years because I happen to step on a rusty nail every 6 or 7 years. There's no such thing as lifelong immunity to tetanus, so that's why we need a booster. And there's probably no such thing as lifelong immunity to COVID either. In fact, we don't really know how long your immune status is to COVID if you've been infected. So we can do these ELISA antibody tests all day long and say, all right, Dorothy, you've got a positive IgM to COVID antibody, hallelujah. And then Dorothy's going to ask me, yeah, but for how long does that work? Does that mean I'm okay for a week? Does that mean I'm okay for a month? Does that mean I'm okay for a year? Does that mean I'm okay for the rest of my life? We don't know. In fact, we don't know what the immune competence duration is of the COVID antibodies. Why don't we know? It's a new disease. How could we possibly know? We've never seen it before. We can take a lot of the hints from SARS virus from 2003, because remember, COVID is a variant of SARS. That's why they call it SARS-CoV-2, because it's SARS all over again almost 20 years later. And we think that the SARS immune competence lasts for at least 1 to 2 years, and that's very good news. So if we can take that type of lesson and extrapolate it to today, we could say that if you have a positive ELISA antibody test, meaning your body has seen COVID, then I could probably tell you if that test result is positive based upon a good ELISA test from the good players that are out there, approaching 100% sensitivity and specificity for the disease. If you give me that result, then I could say chances are you're going to be immune for about 1 to 2 years. And that's very, very good news, because hopefully by that time we'll have a vaccine which would make everybody immune competent, because the vaccine will force us to produce our own antibodies, and then you could go for your ELISA antibody test and see that it's positive. Let's talk about the 2 antibodies that are required for COVID immune response, COVID immune competence. The first antibody is IgG. The second antibody is IgM. Typically in the acute phases of the disease, you will hit high on one, and then on the second convalescent phases of the disease, you'll hit high on the second. So it's always important to have both IgG and IgM as part of your antibody report, and that's what you'll get from the good players that are out there. It's not either one or the other. You want to have both, because that gives us an idea as to how long ago you were actually exposed and what the status of your immune competence is. So bottom line is, we don't really know what is considered to be the neutralizing antibody, meaning is it the IgM, IgG? Which one is the one that actually kills that COVID virus if it comes into your body? We don't really know what the neutralizing antibody is that will give you the immunity that you seek. And then, of course, your second question needs to be, well, how long will I be immune? I can't answer that. We think, based upon the SARS experience from 2003, that it may be at least 2 years. And that would be good news, because that'll give us plenty of time to develop the vaccine that we're all looking for. But remember, different viruses have different levels of immune neutralizing antibody duration. So, for example, I get a flu shot every year. Why? Because the immune competence that I had last year in 2019 is gone by 2020. That immune competence only sticks around for a year. Tetanus, on the other hand, sticks around for a lot longer. So the most important question we have to ask ourselves is, how long, if I do have a positive antibody, is that antibody going to last to give me immune competence so that I'm not going to get reinfected? Right now, we don't know that answer. Estimates are probably up to 2 years, and that's based upon our original information that we had with SARS. And remember, a lot of us are throwing up our hands saying, oh my gosh, it's a brand new infection. What do we do? The sky is falling in. It's not a brand new infection. What we're dealing with of COVID-19 is very similar to what we saw with SARS 2003. It's the same clinical spectrum, the same constellation of upper respiratory, neurologic, GI, cardiovascular, renal types of disorders. So we doctors are very familiar with what's required to maintain good supportive care in the face of this type of infection, because we've seen it before. We saw it 17 years ago, at least I did. You younger doctors probably didn't, but if you talk to an old neurologist like myself, we've seen it, we know what to expect, we're not all that surprised. The point is, we would like to know, based upon antigen exposure, how many people are actually shedding the virus and how many people are actually immune to the virus. And in order to give you that information, I need to have widespread testing on the antigen via PCR, and I need to have widespread testing of the COVID antibody via ELISA. Right now, I don't have that information because nobody has that information, so we can't give you that information. Why is that information important? And here comes the last point of today's discussion. It's talking about this thing we hear called herd immunity, H-E-R-D, herd immunity. What is herd immunity? Herd immunity is what percentage of the population needs to be infected or have seen an illness in order for the entire population to be safe. That's what we mean by herd immunity. This is not a new concept. This is an old concept going back 100 years. The Brits were very interested in this idea of herd immunity to protect cattle from infection. What percentage of the cattle has to be infected so that all the cattle can go out in the field and graze and give us, good Irish butter, or not Irish because that's not British, but give us good British butter and clotted cream. So this is a question that the Brits have been answering for over 100 years. So what do we mean by herd immunity? Herd immunity means the infectious rate, what rate has to hit the population in order for all of us to be immune. And the way you calculate herd immunity, again, here's why you need your envelope, and here's why you need your pen. There's a little formula out there called the calculation of herd immunity. And how do we calculate herd immunity? Well, we take its reproductive rate, meaning I sneeze, how many people did I just infect with that sneeze? That's called the R0, the reproduction zero, the R0. So if we know our R0, our simple equation is R0 minus 1 over R0 gives you your herd immunity. So let's work through that little simple calculation. And this is why I always say, always carry an envelope, always carry a pen. So how do we calculate herd immunity for a disease? COVID, measles, tetanus, HIV. How do we calculate herd immunity for a disease? Well, it's R0 minus 1 over R0. So let's say R0 in COVID is 2. That means I cough, I've just infected 2 people in my space. So R0 is 2. 2 minus 1 over 2 is 1/2 equals 50%. So if I have a cough that infects every 2 people, and then they get infected and they cough and infect every other 2 people, what that says is herd immunity is 50%. And that means 50% of your population has to be infected and survive, obviously, in order to make sure that the entire population is thereby safe. The only way we can possibly calculate herd immunity is if we know the number of people that are out there who have seen the disease. And that's why it's imperative that we have both antigen levels, meaning how many are actually infectious, and how many people have seen the disease and are now recovered, no longer susceptible. And that's where our antibody level comes in. So in order to calculate herd immunity, meaning when can we finally reopen, when can we finally get back to work, when can we finally walk outside on the street and have a reasonable expectation of not getting sick, we have to hit herd immunity. And the only way we can hit herd immunity is if we know who has the disease and who has had the disease. And with that, we can back in to that calculation of herd immunity, which is contingent upon this little thing called R0, R0, the reproductive rate. And if you want to know more about R0, then basically I can back you into that calculation. That's a little bit more complex, but suffice it to say that if we have an idea of who's had the disease via antibody testing and who has the disease via antigen testing, then we can calculate herd immunity. Right now, we think that the herd immunity for COVID is probably anywhere between 1.5 and 1.7. What that means is that 33%, once 33% of the population has it, the entire herd, the entire population is immune. And I'll tell you, if you look at some of these people who are protesting in Michigan, I think herd is the right term for them, not group, but herd, because they look like a bunch of cattle out there on the street. But once we know what percentage of the population has actually seen the disease, then at that point we can back into our herd immunity calculation, and we can all go back to work, we can all go to the theater, and we can all go fly on a plane. But until we get to that point via antibody and antigen testing, we can't really calculate what our herd immunity factor is. There's a lot of things we've been doing to lower the R0, to lower the reproductive rate. And what are those things? Wearing a mask automatically limits your transmission. Distancing yourself from other people automatically lowers the opportunity of transmission. So those are two of the factors that go into that R0 value, that reproduction viral value, from which we get our herd immunity equation. Other things that obviously we can do to help lower the herd immunity value is making sure that the most susceptible people are outside the herd: old folks, people with diabetes, people with cardiovascular disease. So basically, there's a lot of theories out there that when we finally do reopen, we may have different herd immunity values for different people. So for example, if you're 21 to 30 years of age, no health history whatsoever, then obviously you require a very low level of herd immunity value in order to go back to work. So that population may be the first one to go out and reopen everything. Whereas our older folks who have a much higher susceptibility will have a much greater value of herd immunity, because there's really four factors that go into herd immunity. It's duration of disease, opportunity of transmission, the actual mode of transmission, and then susceptibility. Those are the four things that go into that R0 value from which we calculate herd immunity. See, I told you you'd need that envelope. But the point is, we may see a gradual reopening whereby young folks, no susceptibility, who require a very low herd immunity value of, let's say, maybe 5%, meaning only 5% of them ever need to have seen the virus in order to get back to work without chance of co-infection. So that's a population on one end of the spectrum that requires a very low herd immunity value. Whereas older folks, people in their 70s and 80s with lots of metabolic comorbidities, those are folks that are, because they require a high level of herd immunity, meaning a high value, they probably won't be able to engage anytime in the near future until we get better treatments that would minimize their susceptibility. And of course, the gold standard treatment would be a vaccine. Problem with that is it's probably a year off. So, recapping where we've been today, it's imperative that we have good testing of both antigen and antibody. So if you're going to go get one of those tests, make sure that it's a PCR antigen test done in accordance with CDC guidelines. And those are the testing stations that are out there where they swab it into your nose and that data gets reported to the health department. On the other hand, if you want to get an antibody test to see if you've seen the virus because someone in your neighborhood got COVID and you want to know if you were accidentally exposed but never had symptoms and can go back to work because you're quote-unquote immune competent, well, that's a different kettle of fish. And that antibody test requires something called ELISA technology, ELISA. And right now, the only two good tests that are out there seem to be the Abbott and the Roche test. Everything else is just a waste of your time and money and may actually give you false information that could be misleading for your health and the health of your loved ones. So that's why, just like when you buy a pair of shoes, quality is very important. Just like when you're buying a brisket at the butcher, quality is very important. The quality of your antibody test is also very important. And just because someone opens up a website called checkmycovidantibody.com and come and visit me at the back of the mall and I'll take a little prick and I'll give you your result in 24 hours, that doesn't necessarily mean that that's a valid test. And remember, when you're dealing with an incidence of a disease that is probably at this point less than 1% of the overall population, thank heavens, you want to make sure that the sensitivity and specificity of your antibody test is greater than 99%. And most of the stuff that's out there nowadays does not achieve that statistical threshold. So in a low incidence disease that's highly infectious and very dangerous, a low incidence of a disease, you better have a high sensitivity and specificity on your antibody test, because if you don't, the false information that you're getting is going to exceed the likelihood of your getting the disease, and that becomes very problematic, my friends. So, we shared a lot of information today, somewhat geeky and somewhat wonky. That's why I always recommend carry an envelope, always carry a pen, because you can stuff the envelope in your pocket and carry it around and study it when you're sitting there waiting for the next Netflix show to come up. But in the meantime, I just want to remind you, keep your eyes open. As with anything else in life, be a very savvy consumer and be careful of the antibody and antigen tests that are out there, because a lot of them are basically a crock of baloney and won't give you the important information that you need. So on that note, I want to wish you a very safe and sound Monday afternoon. I'm sending you all a virtual hug and an air kiss. And of course, my air kiss would be behind a mask if we were outdoors or if I actually ran into you in public, which is probably not likely anyway. But be that as it may, I'm going to wish you a very safe afternoon, and I want you all to be thinking about herd immunity, and that the people that you're seeing on TV protesting for premature opening, they belong in a cattle herd, not in a human herd. Hopefully everybody on today's Facebook Live is part of the good, intelligent human herd. And on that note, I wish you a great afternoon. Thank you for joining me today. And if you have any questions, please feel free to visit our website, fcneurology.net, firstchoiceneurology.net, but with an FC. And if you have any concerns about your own health as it relates to a neurological symptom like headache, stiff neck, fever, chills, numbing, tingling, nerve pain, please feel free to call me in my office for a telehealth, where I'm here every day to personally assist you with your neurological questions and your needs. And I thank you very much and have a great afternoon. Bye-bye.